We'll call to order the regular Board of Supervisors meeting for Tuesday, August 28, 2012. We will start today with an invocation from Pastor Harold Johnson from Twin View Church, followed by the Pledge of Allegiance by Supervisor Baugh. Pastor?
Let's pray. We're thankful, God, for the opportunities we have to live in a country where we have the freedoms to make decisions that affect all of us, positive things that we can do. We pray for your wisdom as we make decisions in this leadership community that would further your kingdom and also better our society, we pray. For we ask all these things in that name that's above every name. Amen.
Please join me in the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Pastor. Thank you, Supervisor Baugh. Next item will be our public comment period. We ask that you give your name when you come forward. Each speaker is allocated 3 minutes to speak. Comments should be limited to matters within the jurisdiction of the board. Pursuant to the Brown Act, action or board discussion cannot be taken on open time matters other than to receive the comments and, if deemed necessary, to refer the subject matter to the appropriate department for follow-up and or to schedule the matter for a subsequent board agenda. At this point, I have two people who asked to speak. First would be Kathy Grindstaff, followed by Dolores Lucero.
Supervisors, ladies and gentlemen, my name is Kathy Grindstaff, and I am the project director for a Sobering Choice Coalition, and I'm here representing our coalition and members of the community. We want to thank you for all your hard work in adopting ordinances in Shasta County limiting cultivation of marijuana. You are elected by the people, and you are here to represent the people. Well, guess what? Your people are not happy about the lack of action when it comes to the enforcement of the marijuana ordinances that we were so happy you adopted. We have been honored to have Sheriff Basenko, Josh Lowry, Sergeant Barry Powell, and Richard Simon come and speak at our meetings. Yes, your constituents hold meetings to discuss what we can do to make Shasta County a better place to live. Number one was adopting long overdue marijuana cultivation ordinances. Number two, enforcement of these ordinances. And number three, a place to live that is safe for us and our children. We shouldn't be afraid to speak out about our neighbors who are growing pot without consequences, who have people showing up from all over the country doing who knows what right next door. I lost a son to a drunk driver. The one thing I thought that would make a difference is speaking to parents and youth about the dangers of drinking and driving. And I used to think that if I make a difference in one person's life, that would be good. But through the years, I have found that I'm not happy with that. I work every day to make a difference in our community. So, elected officials, you now have the same opportunity to make a difference in our community. It is not enough that you have adopted cultivation ordinances. We now need to see results from enforcement of these ordinances so that we develop a community that will be safe for our children and their children. If you think it doesn't affect you, be careful when you go to sleep tonight, because when you wake up tomorrow, they may be growing right next door to you. Thank you. See you next week.
Thank you, Kathy. Dolores Lucero.
Mr. Chair?
Yes, I'm sorry, go ahead.
That's fine. Do I recall correctly, Mr. Lees, that the ordinance will come up for an automatic review at the one-year mark? And if not, can it?
It absolutely can, yes.
Very good. Thank you.
Okay, thank you. Ms. Lucero.
Good morning. My name is Dolores Lucero. I'm the ex-councilwoman of the city of Shasta Lake. I had a couple things I want to kind of go over, but after what the lady was talking about, I'll throw something in there. First, I'd like to say thank you, Mr. Lee, for basically trying to help the board to understand when there is no money, there is no money to basically to adopt, for the new jail. Unfortunately, I mean, we all would like to have a jail. We would like to have a lot of things, but a lot of times we can't afford it. So I'd like to say thank you for that, because it's important for the board to have someone to let them know there's no money. The other thing, I noticed that Mrs. Sherry Beck is running for the Board of Supervisor, and I see that when she gets up here, she made a comment regarding the jail. I do believe if there's no money, and for her to get up here to say that she basically telling the board to, that you should go ahead and move forward to adopt and to approve, excuse me, to adopt the resolutions or whatever for the new jail. I do believe that she is also, if she's running for Board of Supervisor, and City of Shasta Lake is one of the cities she'll be representing, I do believe I would not vote for her because I see that, she's not considering the public and the people, that this will have an impact on them when you vote on something when you don't have the money. So the citizens will actually have the impact. The other thing is that the lady who actually spoke now a couple of minutes ago here, I did see that she mentioned that regarding the medical marijuana, I do have concerns because I do have asthma, and just the smell triggers my asthma where it puts me in the hospital. And I understand that we need to enforce that. And I understand when you vote to pass the resolutions, it's not only your job to pass and make a better decision for the people, but the people who has to enforce it is the law enforcement. It's the sheriff. And that's where it needs to be enforced. It's the sheriff. And I know he is the one because he has the authority to make that happen. And I'm very disappointed, I guess I have to say, in my opinion, I am disappointed with our sheriff because it is his obligation. But in the same time, he actually swore Rosemary Smith, who carries a 215 card, who's on sitting as a city council member in our city of Shasta Lake. Thank you.
Thank you, Ms. Lucero. Anyone else wish to speak? Seeing none, we'll move on to the regular calendar, R1. Present a certificate expressing appreciation for Christine Waite. Terry, are you going to speak first? Are you going to speak at all? Is it just me? Okay.
I do have a short thing to say. Do you want me to do that first? Okay, now that we got that straightened out, who's speaking first and who's speaking second? Thank you, Chairman Modi and members of the board. I appreciate you taking time out of your busy schedule for this presentation this morning. On November 23rd, 1987, I met Chris. Didn't realize at that time, this is going to be a difficult presentation for me, by the way. Didn't realize at that time that this woman would make a lasting impression on me. Chris is not your average employee. She's an advocate for the child support program, and she is an advocate as an employee of this county. You should be proud of her for that. You can't be in Chris's presence very long before you start laughing, and sometimes holding your stomach from the laughter and the roars that come out of the things that she says and the things that she does. She's a great person to have in the office and keep morale really high. We've often described her as being delightful, positive, full of energy, loyal, kind-hearted, and honest. If you ask Chris about her coworkers, she would tell you that she loves them all and they're all her family. I have to tell you a couple of little stories real quick. Years ago, Chris decided that it was important that everybody in the office on their birthday had happy birthday sang to them. Now, you would remember Chris singing happy birthday to you, the dogs begin to howl, your eardrums hurt, and the dead wake up. Because it is the most horrific sounding happy birthday, but full of love and heart when Chris sings it to you. And we get this every year on our birthday. Everybody in the office does. This morning when I was thinking about what I would say about Chris, I thought one of the things I could say is that I have never ever seen Chris mad at the office. But then I remembered a potluck that we had years and years ago. And one of my job that day was to make sure the refrigerator was cleaned out of all the old food so that the new food coming in, would fit in the refrigerator for the luncheon that day. And another coworker and I were
pulling stuff out of the refrigerator, and I open up this bowl, and it's got this slimy tomatoes and cucumbers and red onion in there, and this slimy looking sauce that had to have been months old that someone forgot, so I threw it away. And at lunchtime, Chris comes in to take her salad out of the refrigerator, and I start hearing around the office, Chris is really mad. Did you guys throw her salad away? I'm like, no, we didn't throw anything new away. We only threw that slimy old stuff away. And Chris's salad was fresh tomato, fresh cucumber, red onion with a nice Italian dressing mixed into it that I had never seen before and thought it was some slimy old salad that I dumped in the garbage that day. So the rest of the day I did stay out of Chris's earshot. A little bit of her Italian temper, I think, actually came out that day. And she's never let me forget about the salad that we threw away that day. But she has always been forgiving. So today, Chris, I am very honored and fortunate to know that you have been in my life. You're a wonderful person and somebody I wish you wonderful luck in your retirement. And I am going to miss you every day at the office. Thank you. Please come up.
Thank you.
Mr. Modi wants to see you. She has family.
How are you?
I'm okay.
I want you to know that when I don't get to eat, I get kind of angry too. So I'm with you. I'd be mad at her too. She threw out my lunch. I'd be grumpy the whole day.
Yeah, I remember that day.
Yeah. Well, I think maybe what instead to kind of get even with her, maybe she should sing her happy birthday right now. I think she deserves that.
I don't think so. No.
Well, Christine, it's my pleasure on behalf of my fellow board members to present this certificate to you. It's always that kind of double-edged sword when we do this, because we are so happy for people who have had a chance to fulfill their dreams at work and now look for other activities and other things to do, yet we lose such a great employee. So we sort of, it's kind of a sad on one and happy on the other. But we are so appreciative of those who work so hard and take in consideration the needs of so many people while they're here and try to spread a little joy. And obviously you've done that in your department. So on behalf of the Board of Supervisors, I'd like to present you this certificate of recognition to Christine Wade. The Board of Supervisors hereby recognizes and congratulates Supervising Child Support Specialist Christine Wade upon her retirement after more than 26 years of outstanding and dedicated service to Shasta County. So Christine, thank you very much.
Thank you.
Sing it, sister, sing it. That is my brother, Tom. I have my sister here. I work with her every day. And I have my wonderful son, Joe, who's sitting right there. Raise your hand, son. To my wonderful coworkers, I really do love you all, and thank you very much.
Joe, could you come up, and Lori, and Chris's brother's here, right? Tom, could you come up for a family picture, please? And who's taking the picture? Julie?
Well, now we have the goods on Miss Love. We can use that whenever we need to. Our next item is R2, presentation from the superintendent from Lassen Volcanic National Park, but she had to attend another meeting in Red Bluff and will not be here until around 9:30 or so. So we're going to skip and come back to this item in a little bit. And so we'll move on to the consent calendar. The following consent calendar items are expected to be routine and non-controversial. They may be acted upon by the board at one time without discussion. Any board member, staff member, or interested person may request that an item be removed from consent calendar for discussion and consideration. At this time, I don't have any requests. Therefore, pleasure of the board.
I'll move approval of the consent calendar.
Second.
Moved and seconded. Mr. Baugh?
And reflect for me a no vote on C5, please. Thank you.
Okay. All in favor of the consent calendar with the one exception, please say aye.
Aye.
Opposed? Motion carries. Moving on to the regular calendar, R3, administrative update and board reports. Mr. Lees?
Nothing to report.
Supervisor Haas?
Thank you. I just wanted to say that Pam Giacomini's back here again today. Welcome, Pam. And in defense of the sheriff, I know I've had a lot of calls on these marijuana gardens. They're all over the place. It's a huge, huge job, everyone. And the staffing is just not there to take care of it and all of these fires at the same time. The sheriff has had many incidences out there to take care of, and evacuations, you name it. I mean, if he had double the men that he had right now, he'd still be short. So we're just going to have to be patient through this period, and we will get there. So I just want to make sure that you all understand that, and that's the reason. You can't have everything with the amount of staffing that we have now and the amount of money we have to spend on it. So we're doing the best we can, I know. And thank you, Sheriff, for what you've been doing, and keep it up. That's all I have to report today.
Thank you. Supervisor Hartman?
I'll pass today, thank you.
Supervisor Baugh?
Thank you, Chair Modi. I attended yesterday a meeting of the Oversight Board for the former Anderson Redevelopment Agency, and I have a packet of information I'll make available to the board. I'll leave it upstairs. I want to point out just the obvious, that all of the oversight boards are going through the same challenges of having to deal with new laws that the state agencies are not able to actually define. So we send back a written plan and a plan of action and a financial plan, and according to the rules that they have presented, and then they're rejected because there are new rules, and legislation recently did take care of a couple of those items, but frankly we expect for them to continue to be rejected until the state actually decides what it is that legislation they actually never really expected to be approved was approved, and it was approved without all of the decisions in place. So it's a frustrating experience, but it is what it is, so we deal with it and move forward. I do want to mention on Saturday there was a great meeting in Shingletown at Black Butte School in regards to the Ponderosa fire, and it was a community informational meeting. Present at that meeting were many of our own staff members, Pat Minturn, we had Rick Simon there, we had a building official there, Mr. Fletcher was there. We had our own law enforcement agencies, other law enforcement agencies besides the Shasta County Sheriff's Department, of course CAL FIRE, a lot of volunteer agencies there, and a lot of people from the public that have volunteered their services as well. To each and every one of them, I just simply want to say thank you. Tremendous effort. It does take a community to put a fire out and to deal with the needs. There was especially something very significant. There was a map on the wall that Mr. Minturn and I were looking at, and by GIS identification, it identified all of the structures that were burned. And I'm sorry to report that there were many houses in Shasta County that were burned. Even one is in any county is a horrible thing, but when you have multiple homes destroyed in a fire, my heart goes out to those folks that are there. We will continue, as the county, to do everything that we can to provide information, answers, and direction. And if there is anyone who's listening to this that is not connected in terms of where to go for questions, I can provide you with some independent information, even agencies that are interested in helping you clean up your property at no cost. If you're uninsured, there are some folks out there that want to help you and they want to volunteer their time and efforts. So my direct line at the county is 225-5584. I would be pleased to answer and help provide any direction in any way that we can as the Shasta County Board. Thank you.
Thank you, Supervisor Boss. Supervisor Kehoe?
Thank you, Chair Modi. I'll also pass.
I'll report that last week I attended the Sustainable Forest Action Coalition meeting in Sacramento with Congressman McClintock and representatives from Congressman Herger and Senator Feinstein's office were there. We discussed a number of issues dealing with the forest, and I also we report that, I think I mentioned it last week, but I will be attending a national coalition conference in Denver in September to help try to draft some language that may be presented to our U.S. Congress to perhaps develop some meaningful use management of our national forests, as far as managing the forest, but also harvesting some of the products, but also protecting it as well. And then had the opportunity also to go to the French Gulch Old West Days last Saturday. Just I think a real unique opportunity for a small community to sort of celebrate their past and how it used to be maybe 150 years ago. Supervisor Haas?
Just want to keep reminding us that we need to be working on an exclusion for all of this dead timber that we're going to have out there so that we can get it harvested on time and not lose it. So we need to be, I guess we start with Herger's office, and we'll ask Darlene these things when she comes in too a little bit later.
Well, I can tell you that that was one of the main topics of discussion at our meeting down in Sacramento as well. So. Okay, we're going to move on to R4, Health and Human Services Agency. Ms. McKenzie.
Good morning.
Morning.
Let's hope we can get the computer to operate. We were having some difficulty. Marta McKenzie, Health and Human Services Agency Director. I'm coming before you today because we have a large contract in the mental health department that's needing your approval and signature. And it comes with some inherent risks from my point of view. And finances have not been wonderful through this recession for the mental health department. And so I wanted to give you the context of this contract and approving it and what it means for the department and for the county of Shasta. I've committed to giving you an update about mental health issues and haven't made it so far. You've received snippets of things. So I'm hoping that some of this today can serve in that stead. As some of you know, or most of you know, I'm planning to end my county service by the end of this year. And I think some of the things that I'm going to talk about will play out perhaps after I've left. And so I don't want to feel like I've left unfinished business relative to the risks that are inherent in the mental health department. I think we'll be talking about a realignment transfer, which we've largely avoided through the agency formation. The agency was formed in 2006, and so far we've not transferred money between the agency, which I think has given us a good start. We haven't pitted parts of the agency against other parts of it. But we've also, over this recession, diminished some of our fund balance reserves, and they're particularly low in the mental health department for some very good reasons that I want to express to you today in relation to this contract. So what you have before you is a $12 million contract. Sounds like a lot of money. But actually, the part that comes to us is much lower than that. What this agreement does is allow us to multiply the money, match the money, do a certified public expenditure to achieve federal Medicaid matching funds, or FFP. This contract was developed between counties and the state in the mid-90s. Realignment happened in 1991, and they consolidated both outpatient and inpatient services to county government, and this was the mechanism by which they gave us the responsibility and some matching funds. We have not had an agreement with the state, though, for 3 years. The Department of Mental Health got tired of sending it to us, I guess, or we got into a place where we couldn't negotiate an agreement. Counties have been in some concerned position about this agreement, so we really haven't had one. Despite that, we've continued to provide services to the community and to our residents, and the state has largely continued to pay us. Both the federal matching funds, which those initials FFP stand for Federal Financial Participation, and state general funds as a match as well in a managed care payment. Lo and behold, the governor decided this last year he was going to shut down the Department of Mental Health at the state level and the Department of Alcohol and Drug Programs. He was successful in the Department of Mental Health. We no longer have that. It was converted to a Department of State Hospitals. And most of the responsibilities, this contract included, transferred to the Department of Health Care Services. We have some practice in public health in the Department of Health Care Services because public health was separated from that department a few years ago. So one goes in and another one comes out. But basically, they've put us in a position of saying no claims for payment, no federal financial participation will flow unless you counties sign this new agreement. So despite the fact we haven't had one in 3 years, we now have one, and they're holding us hostage, literally, in order for monies to flow. So I'm going to encourage you to sign the agreement, but not without telling you some of my concerns about it in the process, hopefully. So what does the contract do? The contract really requires us to target a specific population of seriously mentally ill folks. You'll hear words come out of us of grave disability or functionally impaired in that serious mentally ill population. On the youth side, they're designated as seriously emotionally disturbed because in many cases, kids have lots of behavior problems and other things that manifest themselves, but many times they're not diagnosed until late adolescence or even young adulthood with the serious mental illness, but they have lots of issues before that oftentimes. And the hallmark of this contract is really that it's supposed to be applied for Medi-Cal beneficiaries. It's really the Medi-Cal eligible population that we're providing services through this agreement. Some nuances of the system. It's carved out of the rest of mental managed care Medi-Cal services for physical health needs. We are the sole responsible party in the county government for providing these services to these seriously mentally ill, and separate from and apart from their physical health care. That's caused a lot of problems for this population, who is dying between 25 and a new study 35 years younger than counterparts who don't have serious mental illness, largely because they're dying of tobacco-related conditions, hypertension, diabetes, cardiovascular disease. Our system is not equipped to deal with those, and unfortunately, in covering their mental health care, we often don't have a very good connection with their physical health care providers. And not our fault, it's the way the system was set up to be carved out and separated. Many national studies for the last decade and a half have encouraged the integration of primary care delivery and mental health care to try and improve some of that relationship in the care that's given. In our system, we can provide a broader array of services under the managed care contract than perhaps a medical care delivery system can. We can bill for therapy, case management services. Some of our primary care colleagues would love to be able to bill for case management. We actually have that capacity. We have the capacity to help someone find a home, because many times providing stable housing for a mentally ill person will help their illness and help their recovery if they have some stability in their home environment. Of course, we can also bill for crisis care. That is not true in many other payer mechanisms. Of course, for psych hospitalizations, we can receive some reimbursement, and we provide lots of medication support. We also have the ability to provide services by a broader variety of staff than other systems: psychiatrists, psychologists, marriage and family counselors, licensed clinic social workers, and in fact, staff that are actually waivered. They're either working towards their license or they're under the supervision of a licensed professional. In other systems, those are not billable personnel, so that is an advantage of our system. We operate under a freedom of choice waiver, and for a long time these words were kind of interesting to me, and I thought, well, why would anyone want to waive their freedom to choose where they get care? But in fact, that's exactly what's happened in California. The counties provide this care, and the Medi-Cal beneficiaries who have serious mental illness have to receive their services either through the county or through one of our contracted providers. They do not have a choice about seeing other parts of the system, other parts of the delivery of health care. The mental health plan is what we call ourselves when we sign this agreement to provide this managed care. We have to authorize it, and we have to contract for those services. Federally qualified health centers are a very notable exception, and I think you all know that we have contracts with each of them. They have a federal mandate and allowance to provide mental health care to their population, and very good reimbursement compared to ours. We had 50 cents on the dollar match for our certified public expenditure. Their system pays for prospective payments based upon their actual costs. So for them to see a Medi-Cal beneficiary with a physician and get a prescription for a psychotropic medication, they can gain full reimbursement for that while we can't. So part of the dynamic that we're in now is to try to figure out how we can magnify and multiply the resources available to serve this population with our FQHC partners. We're a preferential provider in the state statute. We've had the ability to be the right of first refusal. Counties were offered this responsibility, and you had a choice to say, no, we don't want to. When I came into the mental health system in '06, I was quite concerned when I looked at the underlying financial underpinnings of this obligation and actually tried to engage State Department of Mental Health with a conversation about, well, what if we refused? What would happen? What would the money look like? What would our responsibilities be? Counties can act jointly. Sutter-Yuba provides a dual system down there. They have a JPA agreement between counties, and we could form, and I think we should give some serious consideration in the years forward about whether or not that would be advantageous to us. Maintaining a single sole county system is getting increasingly difficult. New statutory language was just approved at the end of July, and it used to be that we had language that if we decided not to be the managed care provider, we would enter into a dialogue with the state about how much withhold of our realignment funds they would take to contract with somebody else. That's no longer the case, and the language has been changed to say they're going to sequester funds. They're going to talk to the Department of Finance and sequester our realignment funds if we choose not to be the contract provider. Somehow it doesn't feel like we're on the same team anymore with the state of California relative to this obligation. And in Prop 30, actually, which is the governor's proposal to raise taxes on Californians to support the budget deficit, the first right of refusal actually disappears. So counties will not preferentially be given a right of refusal. And after thinking about this for a long time, it finally dawned on me that this is perhaps an attempt of the state to bring health care into a new system. As you know, some of the changes going on under health care reform and other, we need incentives and financing strategies in health care that incentivize the right players. If I and the mental health system keep someone out of the emergency room, that doesn't save me any money at all. It saves the emergency room and that delivery system. If I prevent an acute hospitalization for some issue, it's not money that's saved into our system. It's money that's saved into the insurance. So increasingly, healthcare is going to be managed in systems that are incentivized for providing better preventive care. The funding, the big issue that brings me before you today. This contract actually supports the flow of FFP dollars, and the bulk of that $12 million is actually those matching funds that come back to us by putting up our county certified public expenditure to get that 50 cents on the dollar. The state gives us about $1 million of state general fund match. At least it's about $1 million now. I'll show you a graph in a minute that shows you how much that's decreased in the last few years. About $6 million flows through 1991 and 2011 realignment, and there's some interplay in the 2011 realignment that I feel needs to be brought to your attention. The county general fund match for realignment is $266,000, and thank you very much. That's continued to flow. And last, I not mention Mental Health Services Act monies can also be used to match Medi-Cal, and because of how the program was conceived and very strong supplantation language that came with MHSA, we've largely used it to provide some innovative and wonderful additional programs to our population. But I think we're going to have to seriously look at leveraging more of those with federal Medicaid dollars as much as we can. And that's perhaps going to cause some anxiety in the community as well as we start to really take a hard look at what some of those programs are and whether or not we need to pull them into our system to be able to match Medi-Cal in a more direct way. This is the mental health realignment curve for the last decade or so, and I need to draw your attention to the dollars on the far side. Because they change from graph to graph. So you'll see we had about $6 million back in 01-02, and guess what? We don't even have $6 million now. And this big dip during the recession. And the problem with realignment is it hangs at that lower level until the economy picks up and you gain it back, but you have to gain it back into growth. So the dollars we lost are more than $1 million for service delivery in Shasta County, and we're down at that lower level now, just trying to eke ourselves back up. So in terms of matching, that's a $2 million set of services potentially that $1 million represents. On the managed care side, this is also what the state has decided to do to us, not because we had fewer Medi-Cal beneficiaries, but because they didn't have any money. So they basically halved our managed care allocation from about $1 million, and you'll see we got a little bit as high as 1.1 million or so in the middle of the last decade, but clear down to 560,000 and now back up to about 900. So not reflective of the Medi-Cal eligible population, but merely that the state was out of money and so they shorted us. So both the realignment dip and the dip in the managed care allocation gives you a graph that looks like this. You've seen this before. We put this in our budget summary documents before the budget process this last year. The yellow is the general fund, Shasta County General Fund match. The dark bars are the realignment, and the blue at the bottom is the managed care. So as you can see, put together, there's pretty significant dip in our revenue. Okay, one of the newest shifts in the Medi-Cal mental health system in 2011, this is public safety realignment. And most of us probably are used to talking about the offender element, which is on this far side of it. But we got these other interesting things that happened to us in public safety realignment. For the first time, drug and alcohol services were embedded with mental health. And even though we've had drug and alcohol services as part of our mental health department for a decade and a half, 2 decades, the money has never been mixed together before. We have 3 separate budget units out of the 15 in the agency that are for drug and alcohol services, and they're separate from the mental health budget. But now we have a shared revenue stream, drug Medi-Cal, drug courts, perinatal drug services, with our big mental health obligations in the same box. The yellow ones are the federal entitlements. We have federal entitlement status for Medi-Cal, for mental health, serious mentally ill. EPSDT, sorry, I probably should have explained that before, that's youth Medi-Cal services. It's called early periodic screening, diagnosis, and treatment, but really you can think of it as youth Medi-Cal. So the concern here is that we now have a lot of pressure in that box of realignment between drug and alcohol services and mental health services that we've never experienced before. Not to mention, in the side box, we have child welfare services, which I've been here to talk to you before, a $35 million operation in Shasta County. It doesn't dwarf the mental health behavioral health system, but it's certainly a bigger system with very significant financial risks to have dollars available to place children when they need to be removed from their families. So we have some ability, you'll notice, to move 10% between them. Yuck, what a great choice that is. A serious mentally ill person or a foster child who needs placement. Not a very good dynamic for the agency on a go-forward basis. There is some legislation that allows Health and Human Services agencies to potentially transfer a bigger quantity of money between these accounts. We're in the process of trying to solidify that we are one of those Health and Human Services agencies and may be able to move additional monies. I probably should have showed you this slide before, but this is what the Medi-Cal beneficiaries have looked like in Shasta County over the last 5 years of this recession. You'll notice between the period starting January 04 through about 07, they were fairly stagnant, about 35,000 Medi-Cal beneficiaries. But since '07, when for us the recession really started, we've seen this upward trajectory. Now, not all those people have serious mental illness, no doubt about it, but enough of them do that there's more folks who are eligible for services under this managed care agreement with, in many cases, declining revenue during the same period. So I would be remiss if I didn't talk a little bit more about the other responsibilities besides this managed care agreement that the mental health department is responsible for. And largely it's similar things, but it's characterized by this as resources allow, which is the other hallmark that you will hear any mental health director talk about. Realignment was never expected, I think, to not have difficulties in financing all the possible services. And so they added this language at the front to be kind of a modifier. For those non-Medi-Cal beneficiaries, you have some flexibility to provide less service. The difficulty is, as someone enters a crisis environment and we need to hospitalize, thank goodness we aren't saying, oh, but you don't have Medi-Cal, so we're not going to help you. We don't do that, thankfully. We move forward to making a decision about hospitalization. But then we suffer the consequences because that client is 100% county cost. So really that no payer source is a really important issue for us and an important issue, I think, for the board as we move forward. If we don't have the resources to provide support to the Medi-Cal beneficiary, the contract's in jeopardy. But worse than that, we have concerns about not being able to finance the things that are outside of Medi-Cal reimbursement. And the language really talks about a system of care from the very most expensive, chronically ill state hospital, which are now costing us about $300,000 a year. They just went up 55% with that new Department of State Hospitals, which is what the Department of Mental Health became. But also the variety of services designed to meet clients where they are with their particular needs. This slide is really intended to show you the juxtaposition in this 5-year period of time between the resources we have available to meet our mental health Medi-Cal obligations versus the resources available or necessary to fund the non-Medi-Cal services. So the top line is the precipitous decline in the managed care allocation to us, the $1 million allocation plus the realignment. The upwards line is how much non-Medi-Cal service we're being expected to provide. And unfortunately, that's increased. So we either have more services being required that are outside of Medi-Cal reimbursement. It's also that we have more clients who are not Medi-Cal eligible who are needing services in our system. So unfortunately, a nice wide margin of flexibility 5 years ago, almost no flexibility now. This is another way of showing the same thing. This is our 2005 versus our 2011-12. How much non-Medi-Cal reimbursed services are being provided out of our system. Upwards of 32% of a bigger amount of money, $7.6 million, down to now 24% of our full realignment and managed care obligation, now at 6.8. 24% of that's going against Medi-Cal now. So that means our service mix has really increased in the non-Medi-Cal reimbursable. So what is it mostly? It's mostly long-term expensive care for people who have Medi-Cal, who are not eligible because these are locked out costs. We cannot recoup costs of state hospital. Even if it's a Medi-Cal beneficiary who needs a state hospital bed, it's a lockout. Just like jail medical services, you cannot have your Medi-Cal benefits when you're in a locked environment. The same is true on the mental health side. We have long-term residential care locations called Institutes for Mental Disease, an awful acronym, IMD. Those are folks who are in a locked environment to protect themselves and to protect the community. But we have no reimbursement for those. Last year they were about $2 million of cost at 100% county cost. So you can see our long-term care obligations for this population have really increased, and those are non-Medi-Cal reimbursable. So that's a big piece of what our expenses are. On the crisis stabilization side, I just wanted to show you a slide about who's coming, who's accessing our services. And the good thing is, I think, that 56% of the folks who are accessing our crisis services have some Medi-Cal coverage, and we can get some reimbursement for it. 4% are other counties' Medi-Cal beneficiaries that we can seek reimbursement for. Medicare can pay for the hospital if we determine that that's necessary, but they pay nothing for crisis care. So for 23% of our population, we're on the hook for the crisis obligation and the responsibility, but no reimbursement to support that. And that private pay population of 20%, those are really the self-pays, the no-pays in most cases, with inadequate incomes and no coverage. Those folks were not able to capture the hospital cost, the crisis cost, any of that interaction. The good news is, no matter what you think of healthcare reform, in 2014, a good number of those folks who are costing us 100% realignment will be covered under Medicaid because they're single childless adults who will become eligible. And the good news is 100%, federal budget notwithstanding and their deficit, 100% reimbursement for that population. So we haven't done the calculations on what that population and resource that might be brought into the system, but it will be an advantage to our current. I just wanted to give you this as the same information in a table form just to show you the types of numbers of encounters for all of those payer sources. And the big number at the bottom, about 1,800 crisis visits a year, about 150 a month, 5 a day is kind of our average for crisis contact. So that just gives you a context of how many people are being served in this system. So for the future, some challenges on the eligibility side, some good, some bad. Those single indigent adults will be covered under Medicaid, hopefully at 100%, so that will ease a little bit of our financial strain. But we have 3,500 new Healthy Families kids coming into Medicaid eligibility. Shasta County is expected to deliver those kids into our system about August of 2013. All of them certainly won't be seriously ill, but some of them will be, and they will become our system's responsibility. You also may see some contracts in the future for our board and care housing environments, and I want you to entertain them with vigor because we've had a closure. One of the reasons we have some expensive IMD costs, in my belief, is we had a closure of a facility, a local facility, about a year ago, and we lost one of our providers who could provide some extra support for some of our individuals. If they can live in a non-locked environment, they can get their Social Security back, they can pay a lot of the rent on their own, and then we can perhaps patch, what we call, enhance a little bit of reimbursement to help stabilize and provide some extra support services. So we really need more board and care options in Shasta County, and we're working hard to bring you some of that in the future. We hopefully will have a local psychiatric health facility. They seem on schedule. They've leased a building. They think they're going to have the state inspectors come in early November. That pressure relief valve for our local community will hopefully result in less hospitalizations. Certainly our experience in July and August so far has proven that to be true. Parity is another one of those bugaboos on the horizon. We haven't got the published rules yet for how mental health care needs to be paritous with physical health care, but those regulations should be coming out this fall, and it may mean that we have more obligations under this contract than we've had in the past. We have an electronic health record conversion going on, which hopefully will result in greater efficiencies in our staff of documentation so we don't miss any potential billable hour. We need to work hard to take our stabilized patients and move them into primary care delivery systems. I told you FQHCs have an independent authority to bill for Medi-Cal beneficiaries. We need to take advantage of that. I think we need to look hard at whether or not we need to form some coalitions in the North State with other counties and try to do this work as a collective. After 6 years on the CMSP governing board, I really saw the power of 34 counties acting together and the shared savings that could be achieved by a central administration. I think that that's a possibility. In Oregon and Washington, their rural counties operate in a regional delivery system for mental health care. I think that's a possibility for the future. And last but not least, there's a letter that I'm asking you to sign as part of this recommendation. There's some concerns that have surfaced around the HIPAA-BA agreement in the contract, and county councils in California have worked together to note their concerns, and so the letter is reflective of those concerns. And it's also reflective of my concerns about this first right of refusal loss and whether or not we really can entertain the idea of not being the managed care provider. Just because we wouldn't be the managed care provider doesn't mean mentally ill people wouldn't have services. It means the state would have to find another mental health provider for our community. And I think it's just healthy for us to exercise the conversation again. We have a different state office to interact with and see what the conversation would be like. The sequestration language is pretty ominous, but I guess I'm up for the try and at least finding out what they would explore with us in the way of an obligation financially. So with that, I'd be happy to entertain questions, and I have the letter, a word or two change in the letter I'd like to suggest. So the letter to Toby Douglas, in the third paragraph down, there's a sentence that begins with, due to the risk of passage of Proposition 30, this is where the first right of refusal language disappears out of statute. Due to the risk of passage of Proposition 30 and the possible inability, I'd like to change that to, possible inability of a county to easily exercise, so two-word changes, easily exercise and possible, its right of refusal, and the sentence goes on and on, but I'm hoping you will entertain those couple modest changes to the letter.
Thank you, Ms. McKenzie. Questions for Ms. McKenzie? Supervisor Ball.
That's a lot of information.
Sorry,
It really is.
it's a complicated system.
As you're presenting all of that, I'm thinking with your pending retirement, that's going to be difficult to replace in a single person.
No, there's lots of folks in the system who understand this work.
Well, I appreciate the depth of your understanding. It is tremendous. And as we listen to it, it obviously becomes kind of a convoluted amount of information. And you did your best to simplify it with the various graphs and charts. But nevertheless, I'm going to try to ask some
Please.
clarifying questions for myself, my own understanding. The biggest thing you said is there's a huge risk. You stated that there's a non-eligible cost, approximately $2 million, and I don't want to misstate that, so please feel free to correct me. 100% county cost. Where does that come from? From the general fund or through realignment, or?
The general fund only contributes $266,788.
And I saw that. So your terminology, 100% county cost. What do you mean by that?
Realignment, mostly.
So realignment.
Yeah. We receive about $6 million in both 1991 and now 2011 realignment. That can be used to match Medi-Cal if it's a Medi-Cal covered service or a Medi-Cal covered individual. Otherwise, we have obligations that are 100% realignment cost. And those are the Institutes for Mental Disease, the state hospital, and a large amount of the hospital cost even for a Medi-Cal beneficiary has not been reimbursable. We've received only about 30 cents on the dollar for a typical hospital day up till now. So it's a part of the hospital cost as well, even for a Medi-Cal individual.
So when you begin the discussion of possible shift in realignment dollars use, that's the reason that you're talking about, because of the increased cost in this area and the challenges of maintaining?
And the good news is, we finished this last fiscal year, our sales tax figures just came in because they come in on the 27th of the month. And last year's sales tax actually increased by 10%. So there's a little growth in the system. The growth in the system will go first to social services because that's where we've had a lot of overmatch and a lot of added cost that we've supported with social services fund balance. So we'll actually have a little bit of extra influx of money for this next year that we hope to receive in the next few months, but we will need to transfer part of that probably into the mental health system to help bolster it up because it has drained itself to a really risky level in terms of fund balance.
How are the reimbursements coming from the state? At one time, we were up to almost $5-6 million behind.
I meant to say that. Even though the monies have flowed, they have flowed slowly in some cases. We go through this complicated cost reconciliation process where we have to stack our actual costs up against the reimbursement we received. And historically, the department always wanted to be owed money from the state. They never wanted to have to send money to Sacramento. And So for the first few years, we were owed large amounts of money, and that was pending. And the state got increasingly behind, and in some cases are a year behind in sending those reconciliations to us. And that's after the year has closed, the cost report has been done, and then we receive the money. It's like 2.5 to 3 years after we've provided the services. So we're a full year behind in that process still, and we have no cost reports for the last 2 years done because the state hasn't figured out how to give us the right instruments that they want the information on. So we're also very far behind in that process right now.
Can you put a dollar sign to that?
No, I really can't. Perhaps Leanne can. She's
Within a
saying
million?
$500,000.
Oh, half a
or
million?
so.
So not as bad as
No, because we've
some
really
points in the
clamped
past.
that down so that we're getting more of the reimbursement at the time that we bill for it, rather than waiting down the road. We've gotten smarter about how to bill the state for the services because we realized it was taking longer and longer.
No change in terms of payment reimbursements because of the change from the governor and who's managing for the state, or is that just from the county and we're
Well,
doing a
this
better job?
contract has this hostage principle
Yeah.
that I'm not very happy about. But we also have some changes because the state has liquidated almost all of their state general fund from these Medicaid benefits. Chesbro actually got a bill passed last year that allowed us to seek more federal limits of payment, since there's no state general fund anymore to be holding us back. There used to be state maximum allowances. And so some of that unreimbursed hospital cost, frankly, was a state maximum cap on their reimbursement. That's been eliminated through this Chesbro bill that happened a year ago. So actually, we hope, once we get our cost settlement process done, that we're able to recoup a little bit more of our cost up to the federal limits rather than have these state-imposed ones that don't make any sense anymore.
And you provide a great segue in your comments there. Your response is the risk of the county in continuing the program versus your own discussion of opening that dialogue, perhaps saying to the state of California, it's your turn. We need to hand it back to you. I know you're saying we'll talk about that down the road, but should we be having a little more of that discussion today? I look at this as a layperson and I say, is there a huge risk here in a local county government not being able to pay for the services that are mandated without reimbursement?
The state's really
and
clear.
do we
Yeah.
end up there then going broke from perhaps eventually the general fund, or realignment dollars simply don't sustain total activities? How do we say yes to something that doesn't have an opt-out?
Well, there is still a termination clause, although it's very buried in this contract now, that counties have 180 days, so basically 6 months to say no.
180?
From my point of view, the timing couldn't be better because we're at an all-time low, I think, in our matching funds to the Medicaid responsibility. When I first came into the department, it was increasing and encroaching. Every year, we were spending more and more of our realignment dollars in matching the Medicaid beneficiary, and I worried about not having enough for the non-Medi-Cal people. But in fact, it's turned the corner, and we have so much expense in the non-Medicaid, it's actually squeezing the Medicaid contract into a very small box, which also worries me that we're not fully discharging this obligation. So in terms of timing to have the conversation, one, we have the first right of refusal potentially being jeopardized by the Proposition 30 on the ballot in November. But two, we have a new administration who I think comes to the conversation with a different frame of reference, if nothing else, and may be in a better position to dialogue with us about the financial risks under this contract and what it would mean if we decided to say no and gave notice.
Thank you for your insight, Marta. I would like to hear, Chair Modi, from our board representative, Supervisor Kehoe, if he would care to maybe add additional conversation.
Before you do that, County Council is asked to speak.
Just very briefly, Ms. McKenzie and I have spoken on these matters to some extent, and there is statutory language that will exist regardless of whether Proposition 30 passes or not that gives counties still the option to opt out of what's called these Medi-Cal specialty health services. It doesn't affect the other items that Ms. McKenzie's talked about, the community mental health and the other things that fall under realignment, the non-Medi-Cal services. But as far as the contract issue, depending upon how it goes, there's still some language that indicates in the statute that while the right of first refusal goes away, it still remains an option for the county legally. Practically, I'll leave it to Ms. McKenzie and Mr. Lees to discuss.
Thank you. Before I yield the microphone to you, Mr. Keel, I have a couple questions.
Sure.
You mentioned about forming maybe a GAPA with other counties to provide some of these services, and I think that's a great idea. I think the opportunity we have to pool our resources with what little we have up here in the North State to make some things happen for the better of the population is a good idea. And you mentioned that it's been done in some other areas. Has there been any discussion or any feelers put out to see if anybody else is interested? I mean, we do a lot of things with other counties already for a number of different areas, and I'm just curious.
If I might take that, Chairman Modi and members of the board, we have actually had initial meetings with other counties yet to be named. I'd rather not go public with that, but we are having some discussions with them on this specific subject. And in fact, their staff met with our staff. I was involved with that meeting as well as their CEO. And it could be the start. There are other counties interested in having a Shasta County-led consortium. And you could see why. I mean, there'd be great benefit to having that certainly with the effectiveness and efficiency of gathering those resources together. And so, yes, in answer to your question, we have moved forward in looking at that. There's some risk involved. Not only are there risks involved with that, but I think it's important to understand there's risk going back to, if I might, what Supervisor Boss spoke of, and that is when you're talking about the potential of saying, okay, we are no longer getting these funded mandates, or our mandates are no longer being funded, we'll give it back to the state. There has been a larger county attempted to do that, and the state has come back and said, that's fine, but we're going to take this realignment money as we deemed appropriate to cover those costs. That is a significant risk because you don't know what pot of money they're going to pull from you and how much they're going to pull from you. And quite frankly, the state wants nothing to, in my opinion. I have to be careful because after the last board meeting, the governor's office called me right after the meeting. So,
What did they call you?
yeah, they didn't like my perception. But there are some risks involved with that. So it's easy to say that, but there could be some other ramification that could actually hurt the county more. And I think, I like the way Ms. McKenzie stated that we have an opportunity here to work with this new administration to see if we can really make a difference and make a change. And hopefully we'll continue to have that support. If it doesn't, certainly I'm not opposed to bringing that back, though, and saying, all right, now we need to take another look at this. This is killing us. We haven't talked about the impacts and increases that we're going to see from our general fund in general assistance programs and things like that. There's other things out there that we're not even addressing that we haven't got to yet today. And so there's other things out there where we need to take a real strong look on what's been mandated and what's the revenue stream to support that mandate.
One of the concerns I'd have if we do join with other counties, I suspect, without you mentioning the names, that we're probably the larger player in the group in that Redding, therefore Shasta County is the hub of Northern California, and we have the majority of the population and therefore a lot of the services. And so I'm sure we'd be dealing with a lot of smaller counties, and so there's always that risk that sometimes we end up taking more than our share of the burden. But I'm hoping it would be just the opposite, that we can actually lessen the burden for everybody by joining forces and making some good things happen.
There's another thing on the horizon, and I talked to you about this probably a couple months ago, this managed care plan for physical health care that all 28 counties are going to be swept into this big system. It looks like we've made some impact in our separation, those 7 counties who wanted to pull out and go separately with perhaps partnership health plan. That may be a 10 or 12 county collaborative that may actually be a better fit for a managed care. So you'd have the physical health side with 10 or 12 counties and the mental health side. And that actually would bring in Sonoma, Solano, Napa, Marin, so some other kind of quasi-Bay Area counties that are bigger than us that might actually be in that same pool if we went with a side-by-side managed care system. So that's another possibility. I think we'll know more in the next week or two whether we're successful in that.
Great, thank you. I have Supervisor Haas on. Go ahead. Yeah, Supervisor Haas?
It was just to mention, how are these small counties making it? See, I don't understand how they're making it now. We're having a tough time, and we're larger, so.
They probably aren't very
I
well.
think there's probably more unmet need.
Yeah.
You know, maybe it's harder to get to an emergency room for someone in psychiatric crisis, so maybe they end up not receiving any services even though they should because the hospital is an hour and a half away. So it may be that there's just more severe illness out there in the community than there is. Here, our folks generally make their way either by law enforcement assistance or otherwise into emergency rooms for crisis care.
Of course, a lot less population, too, so. Okay. Supervisor Keel?
Thank you, Chairman Modi. Ms. McKenzie, thank you for your presentation this morning. Obviously, this is a complex question. It's fraught with imminent peril. And so for the benefit of the board and those in the audience today, briefly, and I underscore briefly, conduct a burden and benefit analysis for us so that this board can make an enlightened decision as to how to proceed. So give us the concerns, give us the risks, give us the burdens, and then give us the advantages. And do this in 37 seconds.
We have insufficient resources in the way of realignment and the managed care contract to fully support or to easily support the number of services described in this contract before you today. However, this contract starts April 1st, and we cannot receive even reimbursement for the services we've already provided, according to the Department of Healthcare Services, without signing this agreement. We also have not exercised our 180-day termination. So at this point, I think I would strongly recommend that you sign it so that we can at least get the money owed. And then we have a deliberative conversation about what the risks are for the future and whether or not we want to explore what it would really be like to say no to this obligation. Did that do it?
That's good. That's good.
Really good. Ms. McKenzie, what about you mentioned that since 2009, the guidelines, the rules to ask for reimbursement that sort of they haven't sent to us to.
Right.
Where do you think we're going to end up with that? Are they going to eventually come through? Or are they just going to hold us hostage for a while? Or
Well, there's
hope we go away?
This is some of the, be careful what you ask for. I think the Department of Health Care Services is a much more mindful of the Medi-Cal system in general. They manage this program for thousands and thousands of millions of beneficiaries in California and pay providers all up and down the state. They now have responsibility for it, and things are seemingly moving quicker forward. We've been told any day now we're going to get the final forms that we have to do the cost settlement process. So I believe that. I think in the organization that's handling $35 billion worth of Medicaid cost in our state, we'll figure out in pretty short order, because they have some federal government obligations for reporting that they have to meet. And they seem to take those more seriously than the Department of Mental Health. So I do believe we'll see soon those cost settlement documents. But we don't think we're owed very much. So it will be an exercise with probably a lot less financial reimbursement coming back to us than the past.
Well, I congratulate you on not trusting the state with your money
Money.
very long. Supervisor Keel.
Thank you, Chairman Modi. Then, consistent with the staff report and the discussion this morning, I'm going to move approval of the staff recommendations A and B. A is to sign a retroactive agreement with the California Department of Mental Health and California Department of Health Care Services, and B is to approve and authorize the chairman to sign a letter of concern as modified this morning to those individuals.
Second.
Thank you, Supervisor Keel. Supervisor Ball, you wanted to add anything else?
Just under discussion, Mr. Lees, is this the best course of action at this time?
Absolutely,
Thank you.
absolutely.
Any other discussion? All in favor, please say aye.
Aye.
Opposed? Motion carries. Thank you, Ms.
Thank you very much.
Chairman Modi, I have another question of Ms. McKenzie.
Uh-oh.
Ms. McKenzie, would you consider remaining a county employee for another 30 years?
Not so much.
Okay, we're going to go back to R2 because I believe Ms. Coons is here, so.
It'll take us just a minute.
Sure. R2 is a presentation and an update from Lassen Volcanic National Park Superintendent Darlene Kuntz on the status of the Reading fire. So we'll take a couple-minute break.
Good job.